Hello and welcome to today's webinar, Quality Decoded, NCQA Public Comment. I'm Cassie Yazzo, Senior Product Marketing Director here at Cotiviti. Thank you so much for joining us today. During our presentation, you may click the Questions tab at any time and submit any questions you may have. We have a lot of material to cover live today, so your Cotiviti account team will follow up on any questions posed after the webinar. We do encourage you to submit your questions with your name visible to us and the anonymous option unchecked, so we know how to get in touch with a response to your question after the webinar. With that, let me introduce our speaker. Samantha Davis is the Manager of Program Management supporting Cotiviti's Quality Intelligence solution. Her team of HEDIS and state and custom program managers are responsible for ensuring adherence to NCQA and state Medicaid specifications. She has over 12 years of experience working in HEDIS, and she is primarily responsible for bridging her knowledge of HEDIS requirements to inform product roadmap, operations, and client collaboration, guiding the organization through the annual HEDIS update cycle. Today, during the second webinar of Cotiviti's year-long Quality Decoded webinar series, Samantha will decode the HEDIS public comment. Each year, NCQA publishes a list of potential measure updates, additions, and deletions for future HEDIS measurement years. Samantha will review the proposed changes, recommend areas of feedback to consider providing to NCQA, and share her observations on how the proposals may impact your data needs. Without further ado, let's turn it over to Samantha.
Thank you, Cassie. We'll be starting off by reviewing the notification of changes for HEDIS. While these make up the very last page of the public comment materials, the notification of changes for HEDIS are always my first stop when reviewing the public comment. These are changes NCQA plans to make for which they are not requesting feedback. So incoming with the measurement year 2024 volume 2 technical update memo that is scheduled to be posted on April 1st, NCQA notes that they'll be adding codes to the pneumococcal conjugate immunization value set for the pneumococcal conjugate 20 vaccine, impacting the childhood immunization status measures. They also noted 4 incoming changes for measurement year 2025. For breast cancer screening, they're considering reducing the minimum age for eligibility to 40 years old, and then stratifying the measure for 40 to 49-year-olds and 50 to 74-year-olds. NCQA is pending implementing this change for measurement year 2025 based on the U.S. Preventative Services Task Force finalized recommendations. They also confirmed that cervical cancer screening, childhood immunization status, and immunizations for adolescents will be transitioning to ECDS-only reporting for measurement year 2025, retiring the admin and hybrid reporting versions of these measures. If you don't recall seeing this when you reviewed the public comment documentation, this item was not on the original version of the notification for changes. NCQA reposted the file a few days after the original public comment opened, so if you download a more recent copy, you'll see it there. For the use of high-risk medications in older adults measure, NCQA plans to add, remove, and regroup medications in this measure based on the latest American Geriatric Society Beers criteria for potentially inappropriate medication use in older adults that was published in May of 2023. They're also planning to remove telehealth visits from compliance for the administrative well-child measures, as these were added temporarily in response to the COVID-19 pandemic and no longer align with the updated guideline recommendations. Finally, NCQA notes that they're postponing the restructuring of the Volume 2 specifications from MY 2025 to now be in 2026 instead. This was originally announced for measurement year 2025 as part of last year's public comment period. One additional bonus item I wanted to add as well. Last July, NCQA posted a blog which mentioned that the antidepressant medication management measure would be retiring with measurement year 2025. While this was not included in the public comment materials, we did see that this retirement was also confirmed in the quality rating system draft call letter that was posted by CMS last week. So that will go into the proposed new measures from the public comment for measurement year 2025. Starting off with blood pressure control for patients with hypertension, this new electronic clinical data systems measure is proposed for all product lines. It includes members 18 to 85 years old as of the end of the measurement year and is proposed to have race and ethnicity stratifications. This measure is designed with a lot of similarity to the existing controlling high blood pressure hybrid measure, but with some key notable changes. The first is that NCQA is proposing to expand the eligible population to include members with one claims-based diagnosis of hypertension and at least one antihypertensive medication dispensing event. They're also proposing to add a second numerator, which would capture patients whose latest blood pressure reading in the measurement year was below 130/80. While NCQA does not note any specific questions for the public comment, they're requesting general feedback on the proposed measure as a whole. While it was noted in the public comment that BPCE is intended to eventually replace the CBP measure in alignment with NCQA's intention in general to retire hybrid reporting, no timeline was provided as to when CBP would be retired in favor of BPCE. We've heard that NCQA is not likely to retire CBP immediately upon introducing BPCE, and that it may take years to complete that transition. They're planning to release a roadmap at some point in 2024 that outlines their timeline for retiring hybrid reporting, but haven't provided any more specific date as to when we may see that roadmap this year. And then for those of you that reviewed CMS's recent advance notice materials, they included a mention of the retirement of the Care for Older Adults pain assessment numerator, noting that they intend to replace that with an ECDS chronic pain assessment and follow-up measure. In that same blog post we mentioned that said that AMM was going to be retired for measurement year 2025. That one also noted COA pain being retired in 2025, but it wasn't mentioned in the public comment. Since we didn't see any references to the new replacement measure for that, we may not see that in measurement year 2025, but we have a pending PCS with NCQA to confirm if COA pain will officially be retiring as per their blog post last year. The next measure NCQA is proposing is documented BI-RADS assessment after a mammogram, which is another measure in the ECDS domain. NCQA is looking to expand their measure set to be more inclusive of follow-up events after cancer screenings, and this is the first of 3 new measures proposed to do so. This measure is also proposed for all product lines and would include members between the ages of 40 to 74 as of the end of the measurement year. This is intended to be an episode-based measure. The eligible population would be made up of all mammograms between January 1st and December 17th of the measurement year. Members who are deceased or in hospice in the measurement year would have their mammograms excluded. For compliance, the member would need to have a documented BI-RADS assessment performed on or within 14 days of the eligible mammogram. NCQA is requesting feedback as to whether the 14-day timeframe is a reasonable expectation for this measure, as well as whether that you would have that information in a structured format within those 14 days. They noted that 3 health plans which participated in field testing of this measure were unable to complete performance rates for it due to the lack of availability of BI-RADS SNOMED codes in their EHR feeds. You may want to consider your health plan's ability to close gaps for this measure within a 2-week turnaround time frame, and whether you have that necessary data available to you in your EHR feeds today. NCQA is also proposing another breast cancer measure titled Follow-up After Abnormal Breast Cancer Assessment, also in the ECDS domain. This measure includes members from all product lines, ages 40 to 74 as of the end of the measurement year, and similar to DBME, this measure would also be episode-based. It would include all instances of a high-risk or inconclusive BI-RADS assessment between October 3rd of the year prior to the measurement year and October 2nd of the measurement year. This measure also proposes to exclude events for members who are deceased or in hospice during the measurement year. The compliance criteria differs depending on whether the eligible episode was high risk or inconclusive. For high-risk episodes, the event would be compliant if the member receives a breast biopsy on or within 90 days after the BI-RADS assessment. For inconclusive episodes, the event would be compliant if the member receives a mammogram or breast ultrasound on or within 90 days of the BI-RADS assessment. NCQA requests feedback on whether the 90-day turnaround time is reasonable for this measure, as well as the appropriateness of the biopsy codes they included in the numerator value set. Similar to the prior measure, if your health plan does not have access to reliable EHR feeds containing BI-RADS data, this measure would also be impacted. So it's worthwhile reviewing this while drafting your comments to NCQA. Cervical cancer screening follow-up is the last of the 3 proposed follow-up measures, once again in the ECDS domain. This measure is proposed for the commercial and Medicaid product lines for members ages 22 to 64 as of the end of the measurement year. The same intake period is proposed for this measure as for BCFE, looking for cervical cytology events of any result between October 3rd of the year prior to the measurement year through October 2nd of the measurement year. However, unlike BCFE, this measure is proposed to only include the first cervical cytology in the intake period rather than all eligible episodes. The cervical cytology events proposed to be included in the eligible population are those with possible or confirmed higher risk cytology results. Members would be excluded from this measure if they're deceased, in hospice, or have a diagnosis of pregnancy in the measurement year. To be compliant, the member needs to receive follow-up intervention on or within 90 days of the higher risk cervical cytology results. Similar again to BCFE, NCQA requests feedback on whether that 90-day turnaround time is reasonable for the measure, as well as the appropriateness of the follow-up procedure and treatment codes they included in their numerator value set. NCQA notes that health plans also struggled in gathering the necessary cervical cancer screening result SNOMED codes when field testing this measure. So we would also recommend evaluating your EHR data sources to see if your plan has access to data with these SNOMED codes when drafting your comment to NCQA. As a measure vendor, we also plan to comment to NCQA regarding the lack of detail in the draft measure specification on how to select the IESD for the measure. The text mentions to use the earliest cervical cytology of any initial result, but they don't give any value sets or further clarifications as to how to specifically choose the IESD. The final proposed new measure from NCQA in the public comment is a new risk-adjusted utilization measure titled Acute Hospitalization Following Outpatient Surgery. This measure is proposed for the Medicare product line and would include events for members 65 years of age and older as of the last day of the outpatient surgery event. While not included in the draft measure specification, NCQA notes they're considering a dual eligibility stratification for this measure, and they're asking for comment or feedback on whether they should add this or not. This measure would be episode-based and split into 4 rates, looking for outpatient colonoscopies, general surgery events, orthopedic procedures, and urology procedures between January 1st and December 16th of the measurement year. They chose these categories to align with CMS's Ambulatory Surgery Center Quality Reporting Program. The measure would evaluate whether these procedures were outpatient based on the presence of an ambulatory surgery place of service code on the same claim line as the associated procedure. Procedures would be excluded from the measure based on the presence of co-occurring diagnoses or procedures on the same claim as the event. This risk measure has a proposed numerator, which evaluates whether a member had at least one acute inpatient or observation stay for any diagnosis within the 15 days after the outpatient surgery episode. Though certain specific diagnoses and procedures on the discharge claim would be excluded from the numerator, such as planned procedures. As a risk measure, members would also be evaluated for their predicted probability of an acute hospitalization, and the standard risk data elements, such as observed over expected ratio, would be reported. Brings us to the end of the proposed new measures for 2025. Next, we'll move into the proposed measure changes. The first measure with proposed changes is the adult immunization status measure from the ECDS domain. NCQA is proposing to add a new numerator to this measure, which would evaluate members aged 19 through 59 as to whether they've been vaccinated for hepatitis B. They state that adding this aligns with the CDC's Advisory Committee on Immunization Practices updated guidelines from 2022. Various methods of compliance are proposed for this new numerator, including adult and childhood hepatitis B vaccine series, hepatitis B pre-vaccination testing with a positive result, and evidence of anaphylaxis to the hepatitis B vaccine. NCQA requests public comment on whether there should be a date restriction for the blood testing option to only include events from the past 7 years, as well as to whether the numerator should be split into 2 different age buckets for 19 to 30-year-olds and 31 to 59-year-olds. NCQA is also proposing to adjust the age stratifications of the existing AISE numerators, which would move the 65-year-old members into the oldest age stratification for each numerator. This, in turn, would also expand the overall eligible members for the pneumococcal numerator from 66 plus to now be 65 plus. NCQA is requesting for public comment on whether the numerator timeframe for the zoster vaccine should be expanded to allow that vaccination to occur anytime after age 19, rather than the current timeframe, which is anytime after age 50. When drafting your comment to NCQA, consider the look-back timeframe on immunizations that you will need to gather for members to be able to report on those childhood and young adult vaccinations for older members. As part of NCQA's efforts to be more gender inclusive in measure specifications, they are proposing updates to the chlamydia screening measure, similar to recent updates they've made to breast and cervical cancer screening measures. When we compare the eligibility criteria for the breast cancer and cervical cancer screening measures to the CHL proposed specification, there's a notable difference in how they are evaluating the sex parameter for clinical use. Where BCS and CCS only evaluate that parameter within the measurement year, CHL is proposed to evaluate it at any time in the member's history. We heard from NCQA that they don't intend to change the eligibility criteria for BCS and CCS for measurement year 2025, so this criteria would differ from how the parameters used in other similar measures. Consider this when replying to your comment for the CHL measure spec. Additionally, NCQA is proposing to include members in this measure who were assigned the sex of male at birth, but have undergone vaginoplasty at some point in their history. They're also requesting comment as to whether plans approve of this additional eligibility option and whether the codes they included in the gender-affirming genital surgery value set are appropriate for identifying vaginoplasty. In the draft measure spec, there are some inconsistencies in the way they defined the exclusions as it relates to sex assigned of birth of male, which may be worth noting as you draft your comment back to NCQA. Also notable here is a note from NCQA stating that sex assigned at birth and sex parameter for clinical use may come from supplemental data sources, as generally eligible population criteria for administrative measures cannot be sourced from supplemental data. This differs from feedback we previously received from NCQA on how to use these codes for the CCS measure for measurement year 2024. So we'll be looking to see if this changes in the technical update materials for CCS coming on April 1st. We noted that the public comment from NCQA only included the CHL measure as proposed for gender changes for 2025. This differs from the CMS advanced notice materials, which mention additional measures such as statin therapy for patients with cardiovascular disease and the osteoporosis measures. As such, these additional measures mentioned by CMS may or may not be in scope of the measurement year 2025 gender inclusivity changes from NCQA. NCQA is proposing some sweeping changes to their follow-up for mental illness measures after hospitalization and after emergency department visit. For both FUH and FUM, NCQA is proposing to update the event diagnosis criteria to allow for any diagnosis position for an intentional self-harm diagnosis. This removes the requirement for it to be instead in the principal diagnosis position. Additionally, they're planning to add phobia and anxiety diagnoses to the mental illness value set, as well as X-chapter ICD-10 codes and suicidal ideation to the intentional self-harm value set. They also propose moving the revenue code for residential treatment services from being exclusionary criteria to instead being a numerator event for both measures. Both measures also had multiple additional numerator event options added, such as peer support and transitional care management. In their request for public comment, they want to know from commenters whether these new numerator options should actually be considered for both measures or only included for the FUM measure. For FUH specifically, NCQA is adding new numerator options that allow for visits with any provider as long as they have a diagnosis in any position for mental health disorder. These numerator options previously required the visit to only be with a mental health provider. This addition would now open up visits from other providers for compliance as well. For FUM, NCQA proposes to remove the principal diagnosis requirement from numerator events to now instead be in any position, as well as remove diagnosis requirements entirely from electroconvulsive therapy and the partial hospitalization and intensive outpatient options. NCQA also notes that recommendations have been made to include school-based services and mobile crisis units as additional numerator options. They're inviting feedback on whether these are appropriate, and if so, how these could be identified with codes if at all possible. The last two measures with noted changes are acute hospital utilization and potentially harmful drug disease interactions in older adults. For AHU, NCQA is proposing to add the Medicaid product line to this measure. The Medicaid product line would only report for 18 to 64-year-olds, not including 65 and up that is included for commercial and Medicare product lines. Additionally, they propose that the outlier classification for Medicaid be members with 6 or more inpatient or observation stay discharges, compared to 3 or more for commercial and 4 or more for Medicare. They state that when they tested this measure, using 6 or more events for the outlier classification represented approximately 1.4% of the eligible members, which made it similar to the percentage of outliers for other product lines. For the DDE measure, NCQA is proposing to remove the total rate, citing that feedback has noted it to be clinically unmeaningful. Additionally, they're also proposing to add anticholinergic agents to the history of falls indicator, aligning with recommendations from the updated AGS Beers criteria. The measure specification draft that they included for DDE also showed some reorganization of the value sets for the 3 measure rates, so that each numerator has its own medication list, no longer having a joint medication list for history of falls and dementia. NCQA is requesting feedback on aligning the medications with those updated AGS Beers criteria, as well as whether the total rate should be retired. The last item up for public comment are recommended changes to the race and ethnicity stratifications. NCQA is proposing to remove the data source stratification from measure-level race and ethnicity stratifications, maintaining only the individual race and ethnicity breakouts. This allows plans to still evaluate measures for racial disparities while reducing the number of additional data elements by 58%. With the way the stratifications are designed now, a single numerator administrative measure has 93 data elements just to represent the race and ethnicity stratifications. With this change, that number would reduce from 93 down to only 39 additional data elements. Similarly, for hybrid numerators, that would drop from 124 to 52, and for ECDS from 155 for one numerator to 65. NCQA would still report on data sources for race and ethnicity demographics through the use of the race and ethnicity diversity of membership measure. So the information for the overall population would still be available for analysis. They're looking for feedback in the public comment as to any potential unintended consequences of removing this component from the measure level stratifications for race and ethnicity. While not noted in their write-up about the proposed changes for race and ethnicity stratifications, NCQA did include a draft of the updated RES stratification general guideline. And if you read through that, you may have noted that any place that they had traditionally mentioned an indirect source, they replaced that with the phrase imputed source. So that's just something to note as we look to receive the Measure Me Year 2025 specifications, specifically when looking at the RDM measure, as to whether we see that naming convention updated to now be imputed source. All right, to close out, consider some of the following as you're finalizing your public comment responses to NCQA. As no definitive timeline was mentioned for the retirement of CBP, It's worthwhile to review how hybrid data is impacting your overall rates for this measure and include any recommendations you have to NCQA on your requested timeline to transition CBP to its ECDS proposed replacement. Additionally, ensure your data teams are involved in reviewing the draft value sets. Many of the new and updated measures are requesting comment on the appropriateness of the value sets, so it is worthwhile gaining an early understanding as to whether your plan has the data needed to report on these proposed codes today or not. Finally, ensure any team members from your side that regularly utilize the HEDIS specifications in their day-to-day responsibilities are reviewing the draft measure specs that they included in the public comment materials closely. Are they finding that the specifications are written clearly with enough detail to understand how the measure should be calculated? Are the various numerator and exclusion options through the draft consistent and not overlapping or contradictory to other measure components? We encourage you to provide feedback on the readability, consistency, and clarity of the specifications to ensure all parties that utilize them, be that vendor, plan, provider, or otherwise, have the same understanding as to what the measure's intent is and its requirements. All right, we made it. Today we reviewed the proposed changes from the public comment. We discussed our recommended areas of feedback to provide to NCQA and shared observations on how the proposals may impact your data needs. We'll know the finalized changes when NCQA publishes their 2025 technical specifications on August 1st. And I invite you to join me again when I host a webinar on September 4th to review those. I'll turn it back to Cassie now to review how to register and wrap us up.
Thank you, Samantha. This was a great and extensive review. For those of you who may not have gotten all of those notes furiously jotting down while Samantha was presenting, she also has a write-up of the proposals in the public comment on the cotivity.com blog if you're interested in reading more or to save as a reference as you prepare with your teams. And we'll also be sharing the recording of today's webinar within the next week. As Samantha mentioned, she will be back with us in September as part of Cotivity's Quality Decoded webinar series. We kicked off this series recently with a webinar reviewing the 2025 CMS Advance Notice that's now available on demand. And we have a webinar coming up on April 25th where our team will review the CMS final rule. If you haven't already, you can sign up for any of these webinars, plus the others you see here by scanning the QR code on your screen or visiting cotivity.com. Lastly, if you submitted any questions during Samantha's presentation, your Cotivity account team will follow up as appropriate. You can also send an email at any time to answers@cotivity.com with additional questions or for more information. This concludes today's webinar. Thanks so much to our speaker, Samantha Davis. We will be reaching out to you via email shortly with a link to the on-demand recording of the webinar. As soon as this session ends, you'll have an opportunity to answer a survey about your experience today. I'm Cassie Yazzo. Thanks again for joining us, and we look forward to seeing you again soon.